Vamos a realizar un trasplante de cristalino. Para ello necesitamos como instrumentos un bisturí, algunas pinzas anatómicas, un suero, sistema de venoclisis y obviamente el ojo de vaca. En este caso, primeramente vamos a retirar los tejidos que no nos sirven para este procedimiento, como ser el tejido conectivo que está periocular, los músculos extrínsecos del ojo. Una vez retirado todos estos tejidos, ya vamos a empezar a hacer la disección, sin antes mencionar un poco de las partes principales que tiene el ojo, como sería el iris, esta capa transparente que es la córnea, y ese otro tejido blanquecino que sería la esclera. Podemos apreciar también en el ojo el nervio óptico. Vamos a ver que todas las señales visuales se transmiten por este par craneal, que sería el número 2, y estos van directamente al lóbulo occipital, en donde la imagen se procesa. Vamos a ver que el ojo se divide en 3 capas, que sería la capa fibrosa, la capa vascular y la capa nerviosa. En la capa fibrosa vamos a encontrar dos estructuras de relevancia, que sería la córnea y la esclera. En la capa vascular vamos a encontrar 3 estructuras de relevancia, que sería el coroides, el cuerpo ciliar y el iris. En la última capa, la nerviosa, encontramos lo que es la retina. Ahora procederemos a la disección del ojo, empezaremos realizando una incisión. También vamos a introducir un sistema de venoclisis, lo que nos va a permitir ayudar a mantener la estructura del ojo y poder facilitarnos de esta forma el procedimiento. Posteriormente realizaremos la extracción del cristalino. Una vez retirado el cristalino, pondremos en su lugar un botón. De esta manera vamos a simular el trasplante de esta estructura.
Traits causing significant visual impairment. Best visual acuity was 21/100ths, and a corneal transplant was the only possible solution to restore vision. The significant overall thinning of the cornea and the absence of significant risk factors for graft rejection led us to prefer the penetrating keratoplasty technique for this case. The donor cornea is prepared using the Baron punch. We opted for 8 mm diameter for the donor and 7.75 mm for the host refine. This will ensure an adequate fit of the graft-host junction. Now we perform the trephination of the host cornea using the Hesburg-Baron vacuum trephine. Note that each complete turn of the spokes advances 0.25 mm into the stroma. And this was a very thin cornea indeed. Only 2 complete turns were necessary to perforate into the anterior chamber. The vacuum should be immediately released and cohesive OVD is injected to fill the anterior chamber. Now the curved corneal scissors will be used to cut the pathological host cornea. This maneuver is carefully performed using both right and left-sided scissors, taking care to avoid damaging the host stromal bed. During this open globe step it is important to keep stabilizing the anterior chamber with OVD, as this will facilitate the cutting maneuvers and reduce the possibility of choroidal effusion. Now gently grab the donor cornea and place it in the trephine area in order to begin the first cardinal suture using the 10-0 nylon thread. Open globe time should be minimized, so in the first suture the priority is to quickly fixate the donor cornea. Ideally the curved needle should pass at about 80% stromal depth, but you will notice that the needle exited too posteriorly in the host side near the limbus. No problem, as after reforming the anterior chamber we will replace this suture. The second cardinal suture is now placed, directly opposite to the first. Notice that in this penetrating keratoplasty technique we will aim to place 16 interrupted sutures, always using a square knot following a 4-1-1 throw sequence to secure the knot. When tightening the knot the surgeon should aim for a firm apposition of the graft-host interface. This is assessed by direct visualization of the interface junction. Also, pulling the thread slightly upwards facilitates the control of knot placement. Experience will of course contribute to a much improved correct suture technique. In this regard the Pollock corneal fixation forceps is a helpful ally in this step. We use it in all PKPs with interrupted sutures as it provides very good control of the graft, and the double-tipped configuration provides indirect visual cues for correctly placing the subsequent sutures. Now that the graft is stabilized we will remake the first cardinal suture, which was too posterior. Notice how with improved stability, the graft now beautifully approximates the host bed as the knot is tightened. Now it is important to rotate and bury the cardinal sutures, as this will create a reference for the subsequent placement of the additional 3 sutures per quadrant. For these additional sutures we follow the same 4-1-1 square knot technique. Notice that these sutures will be placed in pairs, with the second one being directly opposite to the first. In this step the surgeon may opt to bisect the quadrant and place 2 additional lateral sutures, or in this case we chose to progress with the interrupted sutures from the vertical axis towards the horizontal axis. There is a great debate among the preferred technique in order to decrease postoperative astigmatism. The current trend seems to favor a continuous double running suture or combined running and interrupted sutures. These are of course more challenging than the classic 16 interrupted suture technique, and we feel that although the refractive result may be better, there is a greater risk for a single trauma to completely damage and obliterate the running suture. The main advantage of the interrupted suture technique is that the surgeon may selectively remove the sutures guided by corneal topography, in order to optimize the end refractive result. Also, in the case of any suture breaking, it is only necessary to replace the damaged suture. Therefore we favor the interrupted suture technique. We are now completing the core 16 sutures. Next it is of course necessary to rotate the knots towards the stroma. Subsequently we inject BSS into the anterior chamber in order to check for any possible leakage points due to suboptimal graft deposition. Indeed, there was a single leakage point right next to the first cardinal suture, so we will reinforce this area with 2 additional interrupted sutures. Now we check the corneal astigmatism with the Melloni intraoperative keratometer. Based in the placido-corneal ring principle, we verify that there is an expected against the rule astigmatism, which is common in the PKP technique. The final step is to hydrate the strimmal interface, further improving the graft host position. On first post-op day we see a clear cornea and a remarkable absence of intraocular inflammatory signs. The suture is tight and the anterior chamber is formed. Pendocam imaging shows a transparent donor cornea with that tight fit at the graft-host junction.